Good afternoon and welcome to the Inherited Metabolic Diseases lecture. This lecture is being given by special video produced and made entirely by Dr. Lawson because a couple of students each semester have asked to have it presented as a lecture instead of as the review session that we normally give, which is a bingo game to help you remember these diseases. Please understand that the reason is given as a review game is to get you a lot of new questions on these disorders. It also provides you with a way to refresh your memory and help you recall how these diseases work. You have seen all of these diseases already. This is simply a review of diseases that you have already been exposed to in various other forms. On each lecture slide, you have 10 items that are presented. You have the name of the disease at the very top. You have the type of enzyme or transporter that is deficient in the disease in the first point, followed by the normal function of that enzyme or transporter, followed by the substrate or product that is of the missing enzyme. You also get a typical clinical presentation. We're going to spend a lot of time in this lecture going over the typical clinical presentations. You get an explanation of why these work and how the diseases accumulate certain metabolites. You're given how the mode of inheritance occurs, particularly if there's a specific population within the population that it affects more than others, particularly if there is a mode of inheritance such that it occurs in some populations more than in other populations. You will also be given information about the circumstances in which the disease is most frequently occurring, in the circumstances. You also get the procedures that are used to diagnose the disease and the possible treatments. You will note that you had access to this PowerPoint as well as a spreadsheet. I gave you the spreadsheet because it allows you to more easily compare and contrast. There are over 100 diseases that routinely show up on the USMLE and comp exams. These 30 diseases are just a few of those diseases. These are the ones that are considered inborn errors of metabolism, and we will go over those now. There are a large number of other diseases in addition to these, but in the biochemistry department, we want you to start remembering and thinking about these diseases now before you are in the last semester, before you need to take the comp exam. This is your first step in comp preparation. The first disease we're going to talk about is phenylketonuria. There are two forms of phenylketonuria. One is a defect in the actual phenylalanine hydroxylase enzyme. The other is its cofactor. The deficiency in the cofactor is extremely rare. You will never probably see a case of it in your lifetime. However, it is something that shows up on USMLE and comp exams. The most common form is typical deficiency of phenylalanine hydroxylase. The most telling part of the diagnosis of this disease is that the patients smell as though they have been keeping or holding a lot of rodents. They have a very musty smell, much like you smell in a mouse or rat cage. They tend to have slightly lighter skin than their family members, but often we do not see all of their family members, so that's a harder phenotype to detect. However, they usually have very clear intellectual disabilities, and they begin to have an accumulation of phenylalanine without an elevation of tyrosine in their blood shortly after their first feeding in early life. Their urine also will have a great deal of pterin in it as well. This is a slide showing you a number of the amino acid diseases. One is the variant of phenylketonuria that's extremely rare, 1 in a million. That is the disease of the tetrahydrobiopterin disorder. The other is the more common phenylketonuria disorder, but tyrosinemia and alkaptonuria are also shown in this slide. Ornithine transcarbamylase is the next disease we're going to talk about. Again, like the last disease, this comes from your lecture on nitrogen metabolism, which was given to you last semester. In this case, the patient is normally diagnosed because there is a very bizarre ammonia problem. The ammonia in the blood is extremely high, and there's an ion gap that is much less than 20. They will also have low citrulline and low arginine in their blood. You will also note that there is elevated orotic acid in the urine of these patients. The reason there is elevated orotic acid is because the precursor carbamyl phosphate, which is this agent right here, which is a precursor to the ornithine transcarbamylase pathway, is a part of the pyrimidine synthesis pathway. Because the pyrimidine synthesis is also regulated at the step of aspartate transcarbamylase, which utilizes this carbamyl phosphate, because we're pushing too much material because of the overabundance of carbamyl phosphate into the production of pyrimidine synthesis. That causes an accumulation of orotic acid in these patients. Tyrosinemia is a disease that is another failure to thrive disease. Like the other amino acid disorders, you have a smell that is a diagnostic. These patients have urine that smells of cabbages or of rancid butter. But like most of the other amino acid disorders, you have the failure to thrive phenomenon as well, as you may have hepatomegaly. It is important to know that tyrosinemia is most common in people from Canada, particularly in the Quebec region, where it's an extremely common disease, particularly in the one specific region of Quebec. Alkaptonuria, of course, can be spelled with a C or a K here. Alkaptonuria is the last member of that pathway. The people who have this have extreme pain in their weight-bearing joints, but the hallmark to this disease is usually after you take the urine sample and you leave it exposed to air for a period of time in your office, the urine begins to turn brown to black. By 12 hours, it is a dark brownish black, and they will have accumulation of dark pigmentation into their cartilage. That is sometimes able to be seen through the skin, but it's more often found upon surgical procedures. The number of people who have this is relatively rare, only 1 in 100,000 people. The majority of the people who get it are from the Dominican Republic or from Slovakia, where nearly 1 in 20,000 people develop the disease. This is a picture of that cartilaginous discoloration seen where it shows through in the face. It's also seen on this radiographic image where a region of cartilaginous tissue is also showing up as a dark image. There are numbers of dark places for the cartilage here. In homocystinuria, another amino acid disorder, we have a slightly different phenomenon. Although we do see an elevation of the amino acids like we do in all the other amino acid disorders, in this one we actually also see myopia followed by a dislocation of the lens. It is usually the dislocation of the lens which sends the patients in for observation. They may also have abnormal blood clotting, brittle bones, or skeletal abnormalities, but it is the vision problem that tends to send them to be diagnosed. Persons with the highest incidence are people from Germany and are Qatar. Please note that Germans and Qatars are the most common population to be used in USMLE and questions, although Irish people come in as a rounded third for this particular disease. Next is the maple syrup urine disease. Maple syrup urine disease is a disease that is most often diagnosed by the fact that the urine or earwax has a sweet smell to it. It smells a little bit like the spice fenugreek or like maple syrup. If you don't know what fenugreek smells like, you probably know what maple syrup smells like. These children have poor feeding from birth typically. They have abnormal movements and developmental delays like in most of the amino acid disorders. Disorder in a specific population. The population most likely to get maple syrup urine disease is old order Mennonites. And like the other amino acid disorders, we see an elevation in the precursor amino acids that are upstream of the broken enzyme. We also see the elevation of branched chain hydroxy and keto acids in the urine in these patients. This is due to the branched chain amino acids actually undergoing degradation through the urea cycle and accumulating products of the urea cycle. Cystinuria is another amino acid disorder. This amino acid disorder is distinct from all of the others in the way that it is generally diagnosed. It is diagnosed primarily because the child tends to cry and become very upset every time it has to urinate. The child cries when it urinates because it has persistent kidney stones from a very early age. Often these children are diagnosed in early childhood, particularly in the diaper years. When their urine dries just slightly, you can actually see these pink to yellow crystals that turn green in air inside the diaper of the babies. These are hexagonal crystals. They're extremely painful to pass through the urethra, giving the symptom of the crying baby. If it is not diagnosed in early childhood, it can be diagnosed at any time during the lifetime, but these pink to yellow kidney stones that turn green in air when exposed to air is a diagnostic for this particular disorder. Again, you will accumulate the precursors for this enzyme, and you will find it most common in Libyan Jews, and you will find it the least common in Swedes. General population actually has a high frequency of cystinuria. It is a disorder you will probably see in your practice because of its high frequency, but it's extremely high frequency in Libyan Jews. I've included this slide in the presentation so you can see what these crystals look like. This is the cystine crystals. You can see they're extremely jagged. They're extremely large, and they are extremely painful to go through the ureters and then go through the urethra out of the bladder. Some of the other types of kidney stones, although they are extremely painful, they may not be quite as painful in a smaller size as is the cystinuria. Okay, the last of our amino acid disorders is the Hartnupp's disease. We talked about this one in my lecture on digestive enzymes back in second semester because it is the neutral amino acid transporter that is essential for taking in the aromatic amino acids from our diet. Because of its role in doing so, persons with this defect tend to show symptoms only under periods of poor nutrition. At that point, they will get a form of dermatitis and photosensitivity after their period of poor nutrition. You'll remember we had examples way back then that involved things like patients who have been trekking from a war zone into a relief camp, and then the child was diagnosed with Hartnupp's disease. This is the most telling symptom of Hartnupp's disease. It is typically also a renal disease as well, because the same amino acid transporter reuptakes the aromatic amino acids out of the filtrate in the kidneys as well. It takes up all of the neutral amino acids, not just the aromatics, but it is the loss of the aromatic amino acids that lead to a deficiency in niacin and tryptophan, which gives you the pellagra and dermatitis symptoms. These patients always have photosensitivity, and they may have intermittent ataxias due to the lack of niacin and tryptophan in their diet. They will always have tryptophan elevated in their urine. Their urine will also have indoles, which turns their urine a bluish color. Please note, in all the amino acid disorders we have talked about to this point, you always get an accumulation of the amino acid precursor to the enzyme that is affected in the blood or in the urine, and that is one of the major diagnostic indicators. The exception to that rule was with the ornithine transcarbamylase, which was actually a detection of a upset urea cycle and having very high ammonia. Now we're going to move on to the glycogen storage diseases. We will have a series of these as well. The first one is just simply called glycogen storage disease or glycogen storage disease 0. It's a defect in glycogen synthase. It leads to hypoglycemia, as do all of the glycogen storage diseases typically lead to at least some hypoglycemia due to the inability of the body to release glucose when the patient is going between meals. For the glycogen storage disease 0, this disease is extremely rare. There's only been 50 reported cases, and these children tend to have seizures before breakfast or after an inadvertently long time between meals. And these children may be treated with small, frequent meals to keep the symptoms down. Unfortunately, because it is rarely seen, it is often misdiagnosed. And these children typically die of cardiac arrest in early childhood. If it is not diagnosed in early childhood, it tends to be a milder form, and those milder forms tend to live throughout their life and can just simply be managed by these small, frequent meals. This is just a reminder of where glycogen synthase works. Von Gerke's disease is another glycogen storage disease. You will remember Dr. Peterson talking about this earlier this semester, I believe. These patients have an enlarged liver at birth. They have an enlarged spleen at birth, and if it is not relatively large at birth, it will enlarge within the first year. They typically also have enlarged kidneys. It is unusual to see both all three, liver, kidneys, and spleen, be enlarged at birth. That is a very good indicator that this is a von Gerke's case. Of course, you still have to confirm that diagnosis, but it is a good indication if all three organs are enlarged. As with the other glycogen storage diseases, or the majority of other glycogen storage diseases, a hallmark is the hypoglycemia. In this one, there is also lactic acidosis due to the inability to break down glycogen. Glycogen phosphorylase defects has a name called the McArdle's disease. This was also discussed in the glycogen storage diseases lecture by Dr. Peterson. This disease is a little bit different. It tends to not be as severe or as life-threatening as the other two glycogen storage diseases, von Gerke's and storage disease 0, partly because it tends to cause muscle cramps during exercise, and the patients see a second wind after about 10 minutes. They do get severe rhabdomyolysis. That rhabdomyolysis can become so severe that they actually need surgical treatment to release it. This is extremely bad symptom of the disease. Most patients actually will stop exercising after the cramps begin and never go all the way into rhabdomyolysis. This disease is confirmed when we have an elevated creatine kinase showing us the effect on the degradation of muscle. Again, glycogen phosphorylase helps us to break down glycogen and allows us to remove one glucose, 1-phosphate off the end. Now we are going to talk about the diseases of the lysosome. The lysosomal disease, Pompei's disease, is a severe disease as well. It is caused by, an inability to metabolize glycogen properly. This one leads to muscle weakness. Again, all of the glycogen storage diseases at least have some partial effect on muscle weakness. They will have symptoms of hypotonia and the hepatomegaly. In this disease, in Pompei's disease, we also see heart defects. That helps you to differentiate between glycogen storage disease 0 and the others. These all have failure to thrive problems, but in Pompei's we also have breathing problems. These infants are usually diagnosed very shortly after birth. They have difficulties taking their first breath and continuing to breathe on their own. They have failure to thrive, and the hypotonia is extremely severe at birth in these children. They also have the cardiomegaly, which sets Pompei's away from the other glycogen storage diseases. They have myotonia and cardiomyopathy, and they have respiratory distress and weakness. So that really tells you, the combination of all of these really tells you it's more likely Pompei's disease than it is the other glycogen storage diseases. Another carbohydrate metabolism disorder is galactosemia. Galactosemia, uridyl transferase is an important step in uridinylation of galactose. It results in an accumulation of galactose or galactitol or galactose 1-phosphate. These products are actually extremely toxic to the tissues. So without the ability to uridinylate the galactose, we are unable to clear them from our tissues and send them out in the urine. We typically see the abundance of the galactose, galactitol, and galactose 1-phosphate relatively early in early childhood, typically right after the first feeding. We see levels of galactose in the blood prior to the first feeding, and we will also see it anytime the child has gone through certain kinds of fasting events. This is a disease that is most common amongst the Irish traveler population. Irish travelers are a population of individuals who are like the gypsies of Central Europe. They are a nomadic tribe of Irish peoples. Hereditary fructose tolerance is another carbohydrate metabolism disorder due to a lack of aldolase B. In this disorder, we see vomiting and hypoglycemia, as in the glycogen storage diseases, but we also see jaundice, and we see hepatomegaly and hyperuricemia. These patients will also develop kidney failure. We typically find this behavior with the children as we are starting to wean them. They begin to reject the eating of fruits. These are the children that when you try to introduce fruits into their diet, the children will spit out the fruit, claim it hurts them, claim it makes them upset, makes their tummy hurt, etc. And they become very resistant to eating fruits in any forms. So we actually take them off of fruit as they're part of their diet. The next carbohydrate-related disorder is actually you learned about from Dr. Peterson's reactive oxygen species lectures back in semester 1. This is the glucose 6-phosphate dehydrogenase enzyme. In this disorder, the majority of patients do not have a complete deficiency of glucose 6-phosphate dehydrogenase. They typically have a damaged form with lower production. These patients typically develop jaundice, hemolytic crisis, or diabetic ketoacidosis immediately after some challenge to their system by a reactive oxygen species. A common way to get that reactive oxygen species trigger is by eating fava beans, or after a bacterial infection or a viral infection, or taking certain kinds of medications. This disease is also extremely common in African Americans, and it is most common in people from Asia, Africa, or the Middle East and the Mediterranean. It affects some 400 million people worldwide. But again, people do not tend to die from this disease. They tend to have these periods of jaundice, hemolytic crisis, or diabetic ketoacidosis after some sort of reactive oxygen event has occurred. Now we are moving on to lipid disorders. The first lipid disorder we are going to talk about is the medium-chain acyl-CoA dehydrogenase deficiency. A lack of this enzyme or a poor functioning enzyme often leads to sudden death after fasting or an illness with reduced food intake. It is often seen in children in early childhood as a common cause of sudden death immediately after the child has learned to sleep through the night. The inability to release energy from the fatty acids causes an enlargement of the liver, hypoglycemia, with no gluconeogenesis and no release of glucose into the blood from the liver. We screen these babies at birth for this disease because it is a very common disease happening in many populations at only 1 in 4,000 individuals. This disease is characterized by taking and analyzing the heel prick blood samples and looking for plasma carnitine. It is most often diagnosed at birth through that newborn screening in the United States, Canada, and Europe. You can also get a change in the urine dicarboxylic aciduria with low ketones. This is also a symptom of the disease, but is typically the plasma carnitine levels seen at birth that helps us to diagnose this patient. The next lipid disorders we're going to talk about all have been coalesced into a single syndrome. These fatty acid disorders make up what is now called the Zellweger syndrome. The Zellweger syndrome was the recognition that there are a wide number of peroxisome disorders. These peroxisome disorders all turned out to have very similar characteristics, and primarily they are diagnosed by the age of onset. So the earliest age onset is and has always been known as Zellweger syndrome. It is a disease that is the loss of any of the peroxisome genes. It results in extreme hypotonia, poor feeding, loss of vision and hearing in the children after birth. They typically have uncontrolled seizures. The most important hallmark of this disease is when we do MRIs and we look at the brain, we see a persistent breakdown of the myelin in the central nervous system. We actually see these children's brains get smaller and smaller from birth. We detect and monitor the progression of this disease by the MRI method of looking at the volume of the brain, particularly the white matter in the brain, but we also watch the liver function, the coagulation factors, as well as looking at other markers for Zellweger syndrome. Now you're going to notice in the next 3 slides, we're going to basically be underlining the exact same thing. So let me first explain to you this first one that is known as Zellweger's infantile form or neonatal form is always diagnosed in infancy. It occurs in 1 in 50,000 individuals. That is a very high rate of genetic disease that is extremely profound. These children live for only a short period of time and then die. But notice that there is a whole range of Zellweger syndromes now. The type we just talked about is this very early diagnosed kind, and you can see that the way we classify Zellweger's is at the age of diagnoses. But also notice that these children have very similar symptoms, whether they are diagnosed as an infant or they are diagnosed as an adult. In all cases, the white matter of the central nervous system declines with age. The second form of Zellweger's is also known as adrenoleukodystrophy. If you've ever watched the movie Lorenzo's Oil, this is the disease that the child had. The breakdown of the myelin in the CNS is still the primary cause of loss of function in these children and ultimately the cause of their death. Again, we monitor them by MRIs of the brain, their liver function, and the function of their coagulation factors. Refsum's disease is the third type of Zellweger syndrome. Refsum is the old name, as is adrenoleukodystrophy is an old name. These are, again, diseases of the peroxisomes, and again, breakdown of the myelin in the CNS, monitored by brain MRI, liver function, and coagulation factors functioning. And again, you detect all Zellweger's and you classify them on the age of presentation and the severity of the disease. The most severe Zellweger's are those that have the neonatal or infantile onset, and the least devastated individuals are those who have a teenage or adult onset of the disorder. Please note that some abnormalities are consistent through all forms, like the sensorineural, hearing defects, the ocular defects, the tooth enamel defects, as well as things like hepatomegaly and loss of white matter in the brain. The next lipid disorder we're going to talk about is Tay-Sachs disease. You will remember this from Dr. Moore's lectures in first semester and again from Dr. Peterson's lectures on lipid membranes in second semester. This is a disease of hexaminidase A. It results in the buildup of gangliosides in neurons, causing those neurons to regress. This causes a severe disorder of the fibroblasts and leukocytes, and we can actually easily test for hexaminidase activity. This disease is one of many that strongly affects the Ashkenazi Jews. It also affects many French Canadians, Cajuns, and Old Order Amish people. This is very frequent disorder amongst the Ashkenazi Jews. Remember, if in a vignette they tell you the ethnicity of a person, it's probably trying to help you get through to the fact that it is one of the diseases that is at high frequency within that population. This is a diagram to show you the relationship between Tay-Sachs, Gaucher's, Fabre's, Niemann-Pick, Krabs, and metachromic leukodystrophies. Any defect in any of these glucocerebroside metabolisms will lead to the lysosomal storage disorders noted here. It's also shown here, in case you don't remember what glucocerebrosides look like. They look like this attached to this, so that you can see the various pathways here. Gaucher's disease is, of course, another one of these lysosomal storage diseases, a lipid disorder that is a defect of the breakdown of glucocerebrosides. In this case, we normally diagnose the patients because they have high level of bruising and fatigue and anemia. They have a low blood platelet. They also have enlargements of the liver and the spleen. Again, this is a disease that also has a very unusual characteristic, which is you get fat deposits in the sclera of your eye. And so gouters can sometimes be diagnosed during physical exams. This disease is extremely common amongst the Ashkenazi Jews. Although it is a fairly common disease in general, it is extremely common amongst the Ashkenazi Jews. These babies have hepatosplenomegaly, but the most important part when we look at to confirm this disease is we have macrophages, so they look like a partially flattened out crumpled paper. This is due to the development of fibrils within the macrophages. Fabry's disease is another disease of the lipids, particularly the glucocerebrosides. This disorder leads to pain in the hands and feet, but the most important characteristic is you get these angiokeratomas that occur on the skin, often on the arms and legs. These patients also have a decreased ability to sweat. They will have corneal opacities. These dark spots, the decreased sweating, and the corneal opacity can often be detected in a physical exam. They get the accumulation of the globulotriacyl cerebroside in their blood vessels. These accumulations can be extremely large. This is, again, a relatively common disease amongst men. Of course, because it's X-linked recessive, it is not as common in women, but it does occur in women as well. Next, we move on to Hurler syndrome. Hurler syndrome is also known as gargoyleism because the children have rather large heads with very crude features. We say they look like the gargoyles on the sides of buildings. These babies are rather large at birth, with having a slightly above average birth weight. They also tend to initially grow rather fast. They look like they're going to be healthy babies, and then within the first year they begin to slow and then progressively slow their growth considerably thereafter. These children will never get particularly large because of the slowing of their growth. They tend to have hernias, macrocephaly. The macrocephaly and hydrocephaly are two additional very important characteristics of this disorder. These typically result in hepatosplenomegaly. Eye cell disease is the last of these lipid disorders we will discuss. It is a bit rarer disorder, but like Hurler syndrome, we actually see that the lysosomal disorder results in coarse facial features. They do not have the enlarged head, which is the major primary difference that you will see between eye cell disease and Hurler syndrome. They do have restricted joint movements, and they do have, of course, the enlarged organs. In eye cell, they typically have hepatosplenomegaly as well as heart valves that are rather large. They also get an elevation of lysosomal enzymes in their plasma, which makes this disease a little bit easier to diagnose. Next, we're moving on to the heme metabolism disorders. The heme metabolism disorders, we're going to start with Lesh-Nyhan. I believe Dr. Peterson or Dr. Daya talked to you about this disorder when they talked to you about the metabolisms of heme, purines, and pyrimidines. Previously, this disorder is a disorder of nucleic acid metabolism. It leads us to having sand-like crystals in the urine. Again, just as we saw in cystinuria, the sand-like crystals make these babies a little unhappy when they have to urinate because of the kidney stones. These are more fine stones. These are not quite as painful as in cystinuria, but we will often see the sandy-like crystals accumulating in the diaper of the babies. The babies will also as they begin to move about and learn to walk and crawl, will have symptoms of juvenile gout. By the time they are a few years old, it will be very clear that they are having gout syndromes with uric acid buildup. But what really brings us to diagnose this disease is typically not early in life when we can see these sand-like crystals or this juvenile gout, but the fact that when they get about 3 to 4 or 5 years old, they begin to self-inflict injury upon themselves. They will bite their lips, bite the sides of their cheek, bite their fingers, and they will actually damage it, and it actually feels good to them to get whatever is making them feel uncomfortable about their hands and mouth. Usually this child is brought in for the self-inflicted injury, and that is when it is diagnosed. You will find upon running the urine that the urate to creatinine ratio of 2 or higher is found in the urine. This is very indicative of Lesch-Nyhan disorder. Now, in that same heme lecture that you have had, you also learned about acute intermittent porphyria. This is actually, as well as the remaining diseases in this slide deck, are diseases of heme metabolism. In this case, the heme production is interrupted and results in poor localized abdominal pain. These patients typically have painful urination. They therefore retain urine or have urinary incontinence. Their urine turns dark upon sitting, but it's typically darker than average even when it is originally expelled from the body. This is a relatively common disease at 1 in 10,000. We will diagnose it by the elevation in either urine or plasma of porphobilin. Gilbert syndrome is another heme metabolism disorder. This disorder is characterized by jaundice brought on by a stress event like dehydration, fasting, illness, all sorts of things. Even menstruation in young women can bring on a symptom of jaundice. You will see hyperbilirubinemia with these patients, and you will see elevated unconjugated bilirubin in their blood. The next couple of disorders are the Crigler-Najjar syndrome. Again, like Zellweger's, these are disorders that have now been put into a larger syndrome. The type depends entirely upon the age of diagnosis. Like in Zellweger's, type 1 is the most early detected form and is the most severe form of the disorder. So Crigler-Najjar syndrome type 1 occurs in the neonate. We usually diagnose it very quickly after birth due to the high bilirubin after birth. Again, it's a jaundice event brought on by stress, in this case often the act of birth, and we see hyperbilirubinemia. This disease is most often confirmed when the bilirubin is seen to be greater than 20 milligrams per deciliter. It can actually go much higher than this shortly after birth, and we will see these children as extremely jaundiced due to the hyperbilirubinemia, and they will typically have very pale bile. Crigler-Najjar syndrome type 2 typically occurs in children sometime between the age of 6 months through mid-childhood. Again, this is a disease that's diagnosed by jaundice brought on by stress. And again, there's a large number of stressors that can create this jaundice event. We also see the hyperbilirubinemia, and we see elevated bilirubin, but it is typically less than we see with Crigler-Najjar syndrome type 1. These children have between 6 and 20 milligrams per deciliter, and they do have pigmented bile, as opposed to type 1, which had the unpigmented or very pale bile. Another thing that is of interest here is that only in Crigler-Najjar type 2 can you actually treat the patient with phenobarbital. The other forms of Crigler-Najjar treatment with phenobarbital is actually going to harm your patient instead of help. Yet it is a very good treatment for Crigler-Najjar type 2. Dubin-Johnson is the last of the Crigler-Najjar related diseases. It's not actually a Crigler-Najjar disease. It was the one that was excluded from being coalesced because it does not require the stress event to offset the jaundice. It does have jaundice, but it doesn't require a stressor to induce the jaundice. It also is associated with mid-upper abdominal pain, nausea and vomiting, of course. And this one is most common in Iranians and Moroccan Jews who happen to live in Israel or have migrated to Israel. In the lab, you will see hyperbilirubinemia. This is typically less than the hyperstates of Crigler-Najjar, but you can actually see it as elevated. It can be as high as Crigler-Najjar disorders, but what will be the hallmark is that you also have coproporphyrin 1:2 ratio is completely off relative to Crigler-Najjar disorders. Dubin-Johnson is not treated. It is typically extremely mild, and we let them recover on their own. Lastly, we have the last of the jaundice diseases due to heme metabolism, that is Rotor syndrome. Rotor syndrome is typically diagnosed in infancy. It is actually due to a loss of the solute carrier organic ion transporter, but that prevents us from transporting bilirubin into the liver. That lack of uptake results in jaundice as well, giving us the same symptoms as Dubin-Johnson, but the symptoms again are very similar to Dubin-Johnson. We typically differentiate these by the level of hyperbilirubinemia and the ratio of coproporphyrin 1:2. We can also determine the difference between Dubin-Johnson and Rotor syndrome by DNA testing. Again, the jaundice in this case is typically self-resolving, and so little to no treatment is given to the patients. So why should you learn all these diseases? Well, they're going to show up on STEP. These are the diseases that are most commonly show up on STEP of the metabolic disorders. We hope that this also helps to begin to help you realize you need to start preparing now for your comp and USMLEs. I would strongly recommend you take the table that I provide for you and continue to add all of your other known diseases to it so that you have an easy way to study all of the diseases that will affect you on the USMLE and comp exams. If you come to class, we will play bingo with all of these facts, and I encourage you to come to class and participate with us in the bingo game. Besides that, there's $20 of Amazon gift cards sitting on the line if you play. Hope to see you in class. Thank you.